So good afternoon all and welcome to our Practice Staff Virtual Network meeting. I would like to acknowledge the traditional custodians of the lands on which we all meet today and recognise their continuing connection to land, water and cultures. I pay my respects to elders past, present and emerging. Thank you for all that are joining us today for our session, Benchmark Report 101, Understanding Your Benchmark Report. We have three presenters today. We have Randall Ng, who is a Digital Health Project Officer, and Michaela Dwarshes, Primary Healthcare Officer, both from Central Queensland Wide Bay Sunny Coast PHN, and Katrina Pyle, the Operations Manager from Millbank Medical Practice in Bundaberg. I'll now hand over to Randall. He's our first presenter, so over to you, Randall.
Hi everyone, thanks for joining us today. Thanks Amanda. Okay, terrific. All right, so understanding your benchmark report. Let me just move on. What are we going to cover today? Going to cover PenCS software, which is the software that the benchmark report is drawn from. And we're going to talk about what is the benchmark report, what's in it, what can it help with. We'll have a quick tour of the report to see what's in it, and we'll touch on some of the recent changes that have happened in the report. Things like chronic disease management and mental health reviews and changes related to coded diagnosis values. So PenCS software, the PHN provides practices with a license for this software under a data extraction tool agreement, which we sometimes refer to as the DETA for short. There's three main programs that we provide practices with: Cat4, Scheduler and Topbar. Cat4 is the main one that we're interested in relation to the benchmark report. And how it works is it takes a snapshot of your practice clinical database, and then it allows you to run all sorts of different reports and filters to look at that data. A de-identified copy of that data gets sent securely to the PHN each quarter. And using that data, the PHN prepares a benchmark report, which is then provided back to the practices. So Cat4 can help you with getting to know your patient population and with producing lists of certain cohorts. So the example I always like to give is you can use the filters to, for example, look at who your diabetic patients are, and then you can drill down further into that and see which of those diabetic patients have not had their HbA1c recorded in the past 12 months and produce a list of those patients. So Scheduler is just another program that automates the process for collecting, de-identifying and sending that data to the PHN. And Topbar is another program from PenCS that sort of runs in the background and looks at patients who are currently in your practice, and it can provide you with prompts about missing data for those patients. So it's an opportunity to work on your data completeness while the practice is actually there in the practice. Oh, sorry, the patient's actually there in the practice. So what is the benchmark report? It's a quarterly report provided to practices by the PHN. The report's based on the PenCS data, which gets submitted to the PHN by practices under the DETA, and it shows trends in practice data and compares those with the area averages. By area, we mean Central Queensland, Wide Bay, Sunshine Coast or Gympie. They're the areas that we divide the PHN up into. So when you see the area average on your report, it refers to whichever of those areas you come from. What's in the benchmark report? So it has sections on demographics, accreditation measures, quality improvement measures, chronic disease and mental health. What can it help with? It can help with improving data quality and completeness. It can help with working towards accreditation requirements. It can support quality improvement activities and help you to meet the requirements for the practice incentive payment for quality improvement. It can also help with chronic disease management and making the best use of the available MBS items. This is what the report looks like. It's a 2-page report. So on the left we have page 1 and on the right there's page 2. You can see the different sections: demographics, data quality accreditation measures, PIPQI incentive improvement measures, and then on page 2 we've got disease profile, health assessments, mental health profile, and chronic disease management. So now I'll just start to sort of tour through the different sections of the report. At the top of page 1 we've got the demographics section. You can see at the top left we've got that number 7,834 as the total. That refers to your total practice population. That doesn't include any patients that you have archived. And then across to the right you've got the active value. So that refers to your active practice population as defined according to the RACGP definition of an active patient being they've had at least 3 visits in the past 2 years. Then beneath that we've got the Aboriginal or Torres Strait Islander practice population. So this practice has 87 Aboriginal or Torres Strait Islander patients, 68 of whom are active according to that RACGP definition. Then across to the right we have this sort of bar chart which shows the breakdown of your practice population in terms of male and female, and also across the different age brackets. The data quality accreditation measures section. So this section shows the different accreditation measures down the left: allergies, ethnicity, waste, coded diagnosis. In the second column we've got the numbers of patients who have those measures present in their record. So for example, for allergies there's 5,782 patients who have their allergy status recorded, which equates to 95.2% of the active population, and that's compared with an accreditation target of 90%, and also compared with the area average being 93.2%. The one that's a little bit different is coded diagnosis, or coded diagnoses. As you can see, it's not a count of patients, it's a count of actual diagnoses. So what you're looking at there is there's 41,006 coded diagnoses for active patients in the database, and that equates to a percentage of 93.8% of all the diagnoses, regardless of whether they're coded or not, and that's compared to the area average of 74.7%. This was something that was changed recently. We did try expressing this as a number of patients whose records were 100% coded, but that caused the percentage to come down for practices, and there was feedback and discussion around that, and it was decided to revert it back to this way of doing things. One of the main reasons was that it's not always possible to code every diagnosis. There's some situations where there's not a coded diagnosis available. In that case, there's no choice but to free text your diagnosis, and it's not realistic to expect patient records all to be 100% coded. And then across to the right, we've got the graph showing how all those measures are tracking over time across the quarters. Quality improvement measures. As you probably know, there's 10 of these PIPQI incentive improvement measures, but we've split them up into 2 sections. So in this section, we've got 5 of the measures that can be classed as lifestyle factors and screening. So we've got smoking, BMI, alcohol, cardiovascular risk, and cervical screening. They've got notes down below here defining the relevant population for those different measures. And then in the second column, we've showing us the number of patients who in the relevant category who have those measures present, and what that equates to as a percentage of the relevant population, and how that compares with the area average. And again, we've got the graph on the right showing how those different measures are tracking across the quarters. And there's two places in the report where cardiovascular risk is mentioned. Being part of the PIPQI, all these measures are defined by the definitions coming from the Department of Health. And when we get to the other section of the report regarding cardiovascular risk, I'll talk a little bit more about that there. So moving on to the next slide, this is the second half of the QI measures. These ones are all the diabetes and flu vaccination measures. So we've got diabetes with HbA1c, diabetes with blood pressure, diabetes with flu vax, and then the other two flu vaccination measures for COPD and over 65s. Again, we've got the number of patients who have that measure recorded, expressed as a percent of the relevant population and compared with the area average. We've split these values up into two different graphs on the right. We've got one showing the diabetes measures, the HbA1c and blood pressure, and then a separate graph showing how the flu vaccinations are tracking over time. And next is the disease profile section. So we've got the top 5 diagnoses for the practice listed down the left-hand side and shown as a percentage of the active patients for that practice. And then over on the right, we've got a bar chart showing the 5-year risk of cardiovascular event. So this shows patients who have all the relevant data points present to be able to calculate that risk, and it categorizes them into those different risk categories: low, medium, and high. And this one, whereas the other cardiovascular risk values were calculated according to the Department of Health definitions for the PIPQI, these ones come from a report that exists within the PenCS software. But as you can see, there's a note across this one saying there's been an issue identified with that data coming from the PenCS software, and our data team has raised that as an issue with PenCS support at the moment. Health assessments. So we've got data here on the 45 to 49-year-old health assessments, the 75 and over health assessments, and the Aboriginal and Torres Strait Islander health checks. Again, we've in the next column, we've got the number of patients in those different categories. So for example, with 45 to 49-year-olds, there's 430 active patients in that demographic, which equates to 7.1% of the practice population. Just pure coincidence, that's the same as the area average. And of those 430 45 to 49-year-olds, 5.1% of them were billed for the relevant health assessment in the last 3 years, compared to the area average of 9.6%. So with the 75 and over health assessments and the 715s, we're looking at whether or not they had the health assessment in the last 12 months. And across to the graph now, you can see that this the bar here for the 45 to 49-year-olds, the total length of that bar represents all of those 45 to 49-year-old active patients at your practice, and then the color coding represents those who were billed and not billed. So the green section is those who were billed for that health assessment, and the dark region is those who were not. That represents an opportunity for practices to then follow up and, for example, if they wanted to base a quality improvement activity on that, they could use their Cat4 software to produce a list of those 45 to 49-year-olds who've not had that health assessment and work out a strategy for trying to increase that percentage. And then they can use a benchmark report as a guide to track how they're progressing with that. Mental health profile. So in this section, we've got the different mental health conditions listed down the left-hand side. And in the next column, we've got the number of patients, number of active patients who have that condition at the practice, shown as a percentage of your active patients. And then we've got the percentage of those patients with that diagnosis who've had the mental health treatment plan in the last 12 months compared with the area average. And when we get to the review data here, that's showing us we're looking at the patients who've had a plan, and we're saying what proportion of those patients have also had a review in the last 12 months. And again, that's compared with the area average. So if we go across to the graph, looking at anxiety, so that the total length of that bar there is represents that 325 patients with anxiety, and the color coding is showing us that 91 of those patients were billed for a mental health treatment plan in the last 12 months, while 234 of those patients were not billed. And then across to the review section, again looking at the anxiety patients. With the reviews, we're drilling down into that number of those 91 patients who did have a mental health treatment plan in the last 12 months, and we're saying of those patients who had a review and who didn't. So we've got 36 who were billed for a review in the last 12 months and 55 who were not. And that's something that has also changed recently. Previously, with the reviews, we were looking, we weren't only looking at those who had a plan, we were just looking at all patients who had a review in the last 12 months, regardless of whether or not they had a plan. But there was some feedback that practices sort of had an expectation that when we're talking about reviews, we're looking at those who had a plan. So we've changed the report to sort of reflect that expectation. Chronic disease management. So down the left, we've got the different conditions, and in the second column, see that the number of active patients who have that diagnosis shown as a percentage of your active population. And again, we've got the percentage of those patients who had a plan in the last 2 years, a GPMP, compared with the area average. And then for the percentage reviewed, as with the previous slide, we're looking at those patients who did have a plan in the last 2 years, and we're saying what percentage of those patients also had a review in the last 12 months, and that's compared with the area average. So across to the graphs, looking at diabetes at the top there, so the total length of that bar represents those 349 patients with diabetes, and it's telling us that 209 of those patients were billed for a GPMP in the last 2 years, and 140 were not. And over again with the reviews, we're looking down further into those 209 who were billed for a GPMP in the last 2 years, and we're saying how many of those were also billed for a review in the last 12 months. So there were 122 who had a review in the last 12 months and 87 who didn't. So that's the end of the tour of the report. I thought I'd quickly show you, like, this is the PenCS cat recipes page. For those of you who have access to Cat4, this is where you can go to find step-by-step guides to get the information that you want out of the Cat4 program. So this Cat4 is ideally used in conjunction with the benchmark report. So if there's something that you want to work on, you can jump into Cat4, find the relevant recipe, and use that step-by-step guide to find the relevant cohort that you want to focus on, and then you can undertake your quality improvement activities to try and improve that figure on your report. So this just shows you a small fraction of the available reports on that page, and you're not just limited to those reports either. You can create your own reports really using the different combinations of the filters and reports. And this is what the step-by-step guides look like. They just sort of step you through the process for getting the information that you want. This one's showing us how to find over 75s who've not had the relevant health assessment in the last 12 months. And then you can proceed to the next step and actually produce a list of those patients. So you can use that as a recall list if you want to, and call those patients in for a health assessment. So, that comes to the end of my presentation. Thanks very much. I'll hand back to you, Amanda. I think we might be going to take some questions now if there are any.
Thanks, Randall. At this stage, Sharon, can you confirm there's been no questions sent through the chat panel?
No questions thus far. So if anyone would like to start typing those through, we'll quickly try and answer them before we proceed.
Thanks, Sharon. I'll now hand over to Katrina. So Katrina is the operation manager at Millbank Medical Practice in Bundaberg. So I'll just hand it over to Katrina now.
Hi, I'm Katrina. My PowerPoint's not that long or as pretty as Randall's because I don't do PowerPoints. But I have worked 11 years in Bundaberg in a GP practice. Before that, 8 years in skin clinics and a histo lab. I'm 2 years on the Queensland AAPM committee. I'm also a medical assistant, and I have a special interest in beta testing medical software programs and special interest also in research. So I was initially asked to present how our practice uses benchmarking, but I thought I'd just provide tips on what I've learnt along the way. You can only extract out what you put in. I work in a medium-sized practice with 2 nurses, 3 medical assistants, and usually 5 doctors scheduled. Our team all want to provide a good quality medical service to our patients, and I'm lucky they adapt to change. However, for our team to respond to QI, I find that nurse and admin usually lead and manage the way, and trying to get doctors to add in extra things is a little bit more difficult. So I know that, I always get my nurse and medical assistants and admin team to try and lead it where possible and let the doctors get on with their day. Each quarter, I get a report from the PHN, and for us, next page, we put it up in the boardroom. I am aware that some of the practices that I talk to, they email them to team leaders. They put it also in the lunchroom. They present at clinical meetings. For us, I've just sort of put it there and we talk about it briefly at meetings. The results sometimes seem daunting. Before undertaking a QI on your report, you really need to make sure you understand what it means, the number of patients, what the percentage of your patients that are completed, what the area average means. I like looking at this. I feel that if our data is really low, but the area is also low, that I know that it's a common problem for all of us. But you also need to know what data is needed. So for the BMI, what do you need to record for this to reflect on this report? What age does smoking and alcohol consumption include? So that you don't just look at your figure, you have to understand what it means and what age group you should be focusing on. You need to ensure that you have good data. Do you inactivate patients when they transfer practices? Do you run searches to inactivate patients? While the benchmarking report uses active patients, meaning 3 visits in the last 2 years, your database could be huge. So an example, so that's an example in best practice on running a search on how to inactivate patients. And I'm not sure about other software, but I use best practice here. An example for us was in 2019, we had a number of doctors join our practice, both registrars and locums, and we noticed a trend of cervical screening going down. And it didn't make sense because majority of them were female. We had a CST nurse, and it didn't add up that all of a sudden we were showing 30% were having a completed CST. After investigating, we worked out that we were doing the CSTs, but results were not being recorded manually in the data. And the PenCat tool couldn't count the results because the doctors weren't putting the results in. So sometimes you may be doing the data, but if it's not being coded correctly or entered into the correct part of your software, it won't record. So that's something to keep an eye on, because I did notice a lot of the area average for us were the same. They were very low, and a lot of them didn't realise that they needed to add this section in. And new doctors sometimes forget, so they may need a few reminding. You can also opt them out, so then they're not part of that data. Another focus for us was the coded diagnosis. Yes, you can't have 100%, but you can get a clinician to clean up the history and the coded conditions if they want. I noticed that for our practice, a lot of doctors found it easier to free text. I beg, I plead, I threaten, please use coded where possible. An example for us right now is we've got palliative care, but it could have been coded, but they free typed it, so it becomes an uncoded diagnosis. So that's something to also look. So that's a utility function in best practice, but leave it to a clinician to do that. The weight class. So a BMI needs to include both a height and a weight on the same day to record a BMI. For best practice, if you record a height one day and a weight the next day, it will not show a BMI. So knowing that you may be getting a weight every time the patient visits, it may not record the BMI. So try to encourage your nurses and your clinical staff that if they want to get a BMI, they need to enter it on the same day so that it comes across. And that could affect your benchmarking report as well. The cardiovascular risk is another one. It's low. It only picks up the information that is entered. So you need to enter the information into the relevant part of your clinical software. Otherwise, it won't be picked up in the PenCat. They can't read results. They can't read free text in the consult notes. It has to be added into the individual section. Otherwise, it doesn't pick up into your report. In our practice, we've been doing QI for a number of years. All our staff are long-term, so it makes it a little bit easier, except for some of the new registrars. But we have one person who goes through the appointment book each day. It takes about 30 to 40 minutes a day, and they check the normal Medicare concession card, that next of kin emergency contact. Does this patient have allergies and blood pressure? And our new QI is waist measurement. Do they have a baseline ECG if they're in the relevant age group? Do they have their smoking and alcohol updated? And if they don't, then they are moved across to a nurse or a medical assistant to update or organise, if they're outstanding, for any reminders to rebook for another time to get that completed as well. You can use Topper, and there's other softwares out there that can run all the different tools. And if you have any issues, you can talk to the PHN. But start small. Don't expect to do everything on the one in the same month. You know, make sure that your allergies, your smoking, the alcohol, and expand as everyone gets to hang on to a new one. And reward your staff when, you know, like, yay, we've increased our percentage by 10%. Earlier in this year, we did a blitz on next of kin emergency contacts and SMS consent. And the staff pre-COVID asked every patient to update, and they kept a tally on how many patients each of them updated. And each week I'd ask them, how many patients did you do? And over the course of 8 weeks, each staff member who won for the week had a little gift voucher. And it was just trying to get them in the hang. Yes, it's their job and I would expect them to do it normally, but I needed to just uplift and do something different so that they can be incentivized for going the extra mile. Another thing that I heard one of the other practices doing, and we decided to implement it this year, was during flu clinic, while the patients were waiting 15 minutes, we gave each patient a copy of their health summary, which included their next of kin, their medications, any overdue reminders that we had for them, and asked them to review all their details and their medication. If there are any changes or incorrect information, to make an appointment with their doctor or ring admin and update. This was really time consuming. But over the course of 4 to 6 weeks, we had a huge response in patients wanting to know what a current condition was for them and what it meant, and it made sure that they understood what we had on a health summary as well. So being them involved in their health is just as important as collecting the data as well. But that's all I had, unless someone had some questions.
Thanks, Katrina. I've just found the questions from Randall's presentation. So what I'll do is I'll go through those first, and then we'll work down the list. I'm not too sure if there's any for yourself yet. All right, so Randall, are you free to pop back on off mute, sorry?
Yes, can you hear me?
Yeah, so I've just got a question here from Natalie. It's more of a statement, sorry. It would be great to have annotated whether the data comes from clinical or billing software with the numerator and the denominator.
Yeah, good question. I'm not sure. I think all of the MBS billings comes from the billing software. Anything relating to MBS items, but I think everything else is from clinical. So anything to do with like the health assessments, the GPMPs, is based on the MBS items, which come from the billing system.
Randall, that's correct. I can answer that.
Okay. So anything else comes from your clinical system.
Perfect. Thanks, Randall. Another statement from Dr. David McDougall. He has medical centres in every PHN catchment in Queensland. I believe your report is better than any other. Thank you. Kay would like to know if we can add the diabetic cycle of care stats to the benchmark report.
Yeah, we can take that to our data team. There is ongoing sort of review and discussion about what's in the report, and changes do sometimes happen, but we also got to balance it out with the concern about not wanting it to change too much as well, because it's nice to have a bit of consistency with it so you can compare it with previous reports as well. But we can definitely look at that and talk about that with the data team. So I'll make a note of that.
Perfect, thank you. And Marilee, whereabouts in best practice does PenCS pull the data from for our cervical screening? Does it come from investigations or cervical screening manually entered results section?
It does not come from investigations at all. It can't pick up the result. It comes from what the doctor enters into that result box.
Perfect. Thanks, Katrina. And Dr. McDougall again has advised that the Brisbane North PHN has stopped sending out reports. You must log in to obtain them, something they forget to do because they're so busy. Are the Central Queensland Wide-Based Sunshine Coast PHN reports going to continue to be sent out to us, or will it go to our login portal?
We have no immediate plans that I'm aware of to go to a login style of doing it. But I think that is something that has been discussed at times. So I'm not saying that won't happen at some point, but yeah, I don't know if Brad's online, if he has any more information about that.
Thank you, guys. Yeah, so that is something we have considered for having an account online that you can log into and have readily available your benchmark report. It takes a bit of planning to do, but I can't sort of give a time frame of when this will be, but hopefully in the not too distant future, that's something we will have available for practice staff.
Thanks, Brad.
I think we would still be able to provide a hard copy if any practices prefer to get them that way. I think at least.
Perfect. I've just got a comment for you, Katrina, from Shanti. Very helpful and very practical. Thank you. And Meg's got a question. In the patient demographic, does it only show male and female?
Yeah, I think so. I think any other categories were so small that it's very hard to represent them on that graph. But I think there is data available.
On ours, we have it already. It's intersex or indeterminate. It's already showing on the reports if they're in your data.
Oh, on your
Benchmark.
Who was that? Sorry.
Yes.
That was Katrina.
Sorry, that was Katrina. So we have patients that identify differently, and it already shows on the report and has for a little while. So if it's recorded correctly, because now for best practice, they've got a few open different things. If you code them correctly and save it, it will pick up.
Oh, and it shows that on the benchmark report.
Yes.
Oh, okay. Sorry, I wasn't aware of that.
That's okay. I got 4, and it's showing on my July 2020.
Okay, excellent.
Perfect. Thank you. Corinne's just got a question regarding MD and the cervical screening. So when the cervical screening test result is sent through pathology, do the doctors then need to put the data into medical director, or does that happen automatically? Is that a question you're able to answer, Randall? Or we may have to take that one on notice and let her know.
I know might have to take that on notice. I know with some of the pathology results, I think where it can, Penn does pick it up from the investigations, but I think it needs the pathology to be coming in CDA format. So it might, if you're not already receiving it in that format, you might need to contact your pathology provider and request that you get your pathology results in the CDA or atomized format.
Awesome. Thank you. Dr. McDougall again, is anyone still billing a cycle of care? It's no longer a SIP, so most GPs no longer bill that number. That's in Brisbane. Do we know if locally across our PHN whether people are still billing for cycle of care?
Our practice still is, so that it can benchmark itself, that we're completing it regardless of the payment or the SIP.
Perfect. Thanks, Katrina. I've just got a couple comments in. Yep, so there's still a couple practices that are still billing for diabetes cycles of care. Excellent. Alrighty, I'll now hand over to Michaela. So Michaela, I'll just share the screen. Please keep sending the questions through and we'll ask at the end of Michaela's presentation. Over to you, Michaela.
Thanks, Amanda. I'll just start the presentation. Okay, so I'm Michaela Dwarsches. So I'm one of the primary healthcare officers based in Rockhampton. And today I'm going to run through a quality improvement activity using your benchmark report. Okay, so what is CQI? So continuous quality improvement is a quality management philosophy that encourages all team members to continuously ask what can be done better. Think about including in your team, your visiting allied health, your co-located pharmacists, delivery persons, cleaners, and even your patients. CQI is a system of regularly reviewing and refining processes to improve over time. An effective CQI system will improve practice culture, teamwork and morale, skills and knowledge, practice systems, staff satisfaction, patient health outcomes, and business efficiency. So why undertake a CQI activity? Things are never perfect and we're always looking for a way to make improvements. By undertaking quality improvement in your practice, you will improve the patient experience, improve patients' access to care, improve quality and safety, reduce the burden of disease and health inequalities, and improve business outcomes through increased efficiency and effectiveness. So to set the scene for a quality improvement activity, you can use your benchmark report to help understand your practice population. and then agree on a focus area. So for example, this could be via a practice meeting, and it's best to choose a health-related topic and not a process or system. Then appoint a QI leader and team. So the QI leader is not intended to be the only person that does the work, but someone who can definitely lead that type of work with the assistance from others from the team. And it's important to put aside protected time. So this time is away from a front reception or patient contact to develop your focus area and to complete tasks. And then you can set your SMART goal. So what is the SMART goal? It's specific. So what do you want to do? It's measurable. So how will you know when you've reached it? It's achievable. Is it in your power to accomplish this goal? Realistic. Can you realistically achieve this goal? And timely. When exactly do you want to accomplish it? So here we have the sample benchmark report, the same as what Randall went through with you. And we can run through a quality improvement activity from the information in this report. So we can see that we've got 68 active Aboriginal and Torres Strait Islander patients, and our SMART goal could be to increase the number of health assessments completed and claimed by 15% for Aboriginal and Torres Strait Islander patients attending our practice by December of 2020. Or as you can see on the report as well, we have 140 patients diagnosed with diabetes that have not had a GP management plan or a GPMP build. So our SMART goal could be that over the next 4 months, we will increase to 80% the proportion of patients with the diagnosis of diabetes that have had a GP management plan. So setting the scene for a quality improvement activity. So asking the following questions will help formulate your SMART goal, measures and ideas. So what are we trying to achieve? We're aiming to increase the number of completed GPMPs for patients with diabetes. How do we know a change is an improvement? Well, we can check the progress using the PenCat tool and looking at our benchmark reports. And over time, we will see the increased number of GPMPs claimed. So what changes can we make that will result in an improvement? Well, we could recall patients that have not had a GPMP claimed in the last 12 months, and we could use software prompts to remind GPs and opportunistically identify patients as they book. So with this information, we can complete a PDSA template. So P, plan, what exactly do you want to do? So as an example, on Wednesday, the practice manager will do a search to identify all patients with diabetes who have not had a GPMP in the last 12 months. Then on Thursday, the practice manager will recall the first 40 patients of Dr. X via SMS from the list so they can make an appointment. And we're going to predict that 70% of patients will attend. So was the plan executed? So yes, on Wednesday, the practice manager printed off the list of diabetics who hadn't had a GPMP completed in the last 12 months. The practice manager sent the SMS to the first 40 patients on that list, and the list was given to reception, and the receptionist noted patients that called for an appointment as a result of the SMS. So study. So this is where you record, analyse and reflect on the results. So as a result of this, so there was 349 patients coded with diabetes, 140 patients did not have a GPMP. So of the 40 selected, 30 responded. Of the 30 who responded, 25 patients made an appointment, as 5 couldn't make it at that time. So it was decided that recall via SMS was deemed a success and will be used again. And this is showed as we exceeded our response by 5% with a 75% response rate. So then act. So what will you take forward from this cycle? So the practice nurse will call 10 patients that didn't respond to the SMS and seek to understand why, and will make appointments for the patients over the next 2 weeks. And reception staff will call and make appointments for the 5 patients that could not make an appointment within the original time frame. Some other tips as well when completing a PDSA cycle. So the QI team could have a quick meeting to discuss the findings of the study and decide on further activities, or this could be discussed in a practice meeting. And remember, you only need to start small. We're just testing the ideas. So you could focus on one GP at a time with a small sample of patients to see if it'll work. And to identify the patients, you can use the pen tool, the benchmark, or software searches, or a combination of all 3. And you can download a PDSA template on our webpage, and we've also got a PDSA in our handouts today. And each PDSA should take no longer than 1 week to complete. So using the previous example, over the next 4 months, the QI team and other team members should be able to achieve the goal of increasing to 80% the proportion of active diabetic patients who are regular patients of Dr. X that have had a GP management plan claimed within the past year. The team should also be able to improve the processes in the practice in a way that can be scaled to other GPs and practice-wide. So the aim of this is for the process to become business as usual, or this is the way we do things here. Reporting these findings and progress to the broader team is also important, and this can be done via a practice meeting or via the notice board in the staff room. And as the team slowly improves the systems and processes, the delivery of care for patients living with diabetes will improve. So what next? So now the process is refined, we can scale up and contact all patients with diabetes without a completed GPMP in the practice. However, we discovered that we didn't have enough appointment spaces to accommodate the large number of calls in relation to the SMS recalls that were sent. So some ideas to fix this include perhaps splitting the SMSs, so send out maybe 50 a week and send the mid to late part of the week, and don't send them out during busy times, for example, flu seasons, and monitor how many appointments that you have available each week, and allocate staff with protected time to complete these tasks and check on this. So on our website, you'll be able to find a wide range of quality improvement toolkits covering the following topics. So building the health service team, cardiovascular disease prevention, continuous quality improvement and implementation guide. There's COPD, diabetes and osteoporosis toolkits, advanced care planning quality improvement quick guide, and a COPD QI quick guide. Okay, that's all from me. So if there's any more questions, please send them through.
Thanks, Michaela. There's been no more questions come through the chat pane. I'll just give everyone a couple seconds to send any comments or anything through. But I'd like to thank Katrina, Randall and Michaela for presenting for us today. We hope that everyone's been able to take something from these presentations. Actually, we've just had a comment through from Dr. McDougall. We found that it was a mistake to send SMSs on a Friday. Patients phoned over the weekend when we had middle reception staff. That's a really good point. So thank you, Dr.
Yeah, that's fantastic to know.
Yeah. Otherwise, thank you to Katrina, Randall and Michaela. We really appreciate your time today, and thank you to everyone for attending.